This is the fifth video in this series on shock, and the topic is pressors. The learning objectives are to be able to describe the different receptors used in the control of vascular tone, to be able to list the effects of common pressors on systemic vascular resistance and cardiac output, and last, to be able to choose an appropriate pressor in a patient with hypotension and shock. Control of vascular tone is an incredibly complex process. There are some compounds that cause blood vessels to constrict, for example hormones like epinephrine, norepinephrine, angiotensin II, and antidiuretic hormone, which is also known as vasopressin. Neural input via the sympathetic nervous system also stimulates vasoconstriction via the release of norepinephrine at synapses, and local factors contribute as well, such as endothelin, which is predominantly produced in response to vascular injury. Other compounds cause vasodilation. Hormones doing this include ANP and BNP, bradykinin and histamine, and local factors include nitric oxide and adenosine. This isn't a physiology lecture, so I'm not going to be reviewing this process in great detail, but will just focus on the compounds most relevant to the treatment of shock. The most important vasoconstricting compounds in the body are catecholamines. These are compounds which all contain the catechol functional group, and as its name implies, an amine group as well. Endogenous catecholamines include dopamine, norepinephrine, and epinephrine. Note the strong structural similarities here, and in fact, they actually form a chain in a biosynthetic pathway that begins several steps before dopamine at the amino acid phenylalanine. There are also synthetic catecholamines which are used as medications to alter hemodynamics. They include dobutamine, phenylephrine, which strictly speaking is not actually a catecholamine, and isoproterenol, known in some parts of the world as isoprenaline. The first 5 of these drugs play an important role in the management of shock, in which these small differences in structure can result in significant differences in hemodynamic effect. The last drug, isoproterenol, is rarely used as a second or third line agent for symptomatic bradycardia, but is poorly tolerated and won't be discussed further today. The different actions of the other drugs are a consequence of differences in which receptors they act on. Catecholamines affect hemodynamics by binding to adrenoceptors, which are a group of transmembrane proteins that transmit signals to second messenger systems within cells throughout the body. There are 2 major groups of adrenoceptors, alpha and beta. Activation of alpha-1 receptors leads to vasoconstriction and thus increases SVR. Activation of beta-1 receptors leads to inotropy and chronotropy, which means increased contractility and increased heart rate, respectively. The net effect is a dramatic increase in cardiac output. And activation of beta-2 receptors leads to vasodilation, which decreases SVR. There are also alpha-2 receptors and beta-3 receptors, but their actions aren't relevant for this discussion of shock. Now, let's look at the 2 main endogenous circulating catecholamines, norepi and epi. At physiologic doses, norepi's main actions are on the alpha-1 receptor, with minor action at the beta-1 receptor, and no action at the beta-2 receptor. Epi's main action is on the beta-1 and beta-2 receptors, with a minor action on the alpha-1 receptor. Thus, norepi contributes more to maintenance of sufficient blood pressure in normal individuals because the vasodilatory effect from epi's beta-2 agonism partially cancels out the minor vasoconstrictive effect of epi's alpha-1 agonism and its increased cardiac output from beta-1 agonism. In other words, at low doses, epi does not have a tremendous effect on blood pressure. If you have any clinical experience, this might seem counter to what you've observed when treating patients with shock with epinephrine or treating patients with anaphylaxis with epinephrine. It almost always increases the blood pressure when given pharmacologically, sometimes dramatically so. But that's because the doses administered in medical emergencies far exceed normal physiologic levels. When epi's concentration is increased to supranormal levels, its action on alpha-1 receptors becomes more prominent. This is just one of several notable examples of the dose dependency of receptor selectivity. And that is just one factor contributing to the complexity of the control of blood pressure. There's multiple compounds which have effects across multiple receptors, and the relative strengths of those effects are dose dependent. With that in mind, let's take a look at a table summarizing the effects of all significant endogenous compounds and synthetic pharmaceuticals. I've added in 2 additional compounds which are not catecholamines, the previously mentioned vasopressin, which is a naturally occurring hormone, and a medication called milrinone, which belongs to a class of drugs called phosphodiesterase inhibitors. And I've listed some hemodynamic effects of each, specifically what happens to SVR, heart rate, cardiac output, and blood pressure. Some of these hemodynamic effects are the direct consequences of receptor activation, and some are the indirect reflex responses. For example, phenylephrina's only direct effect is increasing SVR via alpha-1 agonism. However, the increased afterload leads to a decreased cardiac output as a secondary reflex effect. This table is incredibly complicated. There's simply no way you're going to memorize or remember this, nor should you try, particularly since the number of plus signs or up arrows in a particular location is partially arbitrary, and multiple reliable sources contradict one another with the specifics. But luckily, this chart can be vastly simplified and still remain clinically useful. Consider the following 6 drugs in this order: phenylephrine, norepi, epi, dopamine separated into high and low doses, dobutamine, and milrinone. I've left out vasopressin because it's only used as a second-line agent in septic shock, and I've left off isoproterenol because it's not used in shock at all. Now, next to this list, place these relative scales: increased SVR down to decreased SVR, and increased cardiac output up to decreased cardiac output. This simplification is not perfect. For one thing, the point of no net effect are at different points for SVR and cardiac output. Specifically, it's low-dose dopamine that has approximately no effect on SVR, and it's between norepi and phenylephrine when the effect moves from mildly increased cardiac output to decreased cardiac output. But this simplification still gives you the general idea, and it's much easier to remember than the previous chart. This is also a good point to stop and discuss just what the term pressor refers to. I did not define it earlier because it's not as clear a concept as you might think. In the most general sense, pressors are drugs, usually administered via a continuous IV infusion, which either increase the SVR or increase the cardiac output. Drugs which do the former are known as vasopressors, and drugs which do the latter are inotropes. So from this chart here, we can see what is what. Phenylephrine increases SVR, so it's a vasopressor. Dobutamine and milrinone increase cardiac output, so they are inotropes. And norepi, epi, and dopamine increase both, making them both vasopressors and inotropes. At this point, I'm going to move away from discussing the pharmacology of pressors and start talking about their clinical use. Specifically, how does one choose a pressor? The most fundamental principle here is to always attempt to address the deranged physiological parameter. For example, in a patient with pure distributive shock, does a pure vasoconstrictor seem like a good idea? Yeah, probably. There's a little asterisk here that I'll come back to. For a patient in cardiogenic shock, does a pure vasoconstrictor seem like a good idea? Absolutely not. So now let's get a little more specific. What are the first-line agents for septic shock? Norepi or phenylephrine, again with that little asterisk. For refractory septic shock, that's when we add either vasopressin or epinephrine. For cardiogenic shock, the historical conventional choice is dobutamine with or without dopamine, usually depending on whether additional blood pressure support is necessary, as dobutamine does not necessarily raise the blood pressure on its own. However, dopamine is sometimes used as a single agent, and more recently some clinicians have been using norepi with or without dobutamine as the pressor of choice here. This last option is based on the outcome of a very controversial and problematic trial that I'll come back to in a few minutes. What's the first-line pressor in hypovolemic shock? It's a trick question. IV fluids only and no prolonged pressors. If you are needing to give pressors to a patient in hypovolemic shock, it means you have not yet given them enough fluids. But if it's necessary to give pressors to prevent hemodynamic collapse as fluids are still running in, I don't think anyone has any idea which pressor is best. And last, for either mixed septic and cardiogenic shock, or for shock of unknown etiology, norepi is probably the choice that would be least frowned upon, but we don't know if it's truly the best option. Some clinicians use epi here, and others dopamine. I'm going to talk for a minute specifically about phenylephrine use in septic shock. You'll remember that asterisk. Well, here's what it's about. The well-respected Surviving Sepsis campaign released guidelines in 2012 in which they stated, quote, "We recommend norepinephrine as the first choice vasopressor," and continued with, "Phenylephrine is not recommended in the treatment of septic shock except in the following circumstances. Norepi is associated with severe arrhythmias, cardiac output is known to be high, and other approaches have failed." So why is this? They don't really give a good reason in the 2012 guidelines, though the inclusion of the second circumstance suggests one. Remember from a few videos ago that septic shock can be associated with transient myocardial dysfunction on account of sepsis-induced cardiomyopathy. It seems like the Surviving Sepsis campaign is concerned that this secondary myocardial dysfunction may go unrecognized, and that placing such a patient on a pure vasoconstrictor would be dangerous. So, if you don't know exactly what's going on with the hemodynamics, I agree, stay away from phenylephrine. But if the patient has either a PA catheter or high-quality echo, and myocardial function appears to be intact, phenylephrine would seem to be a perfectly acceptable alternative to norepi here. In the 2016 update to these guidelines, the committee also cites a lack of high-quality evidence supporting the use of phenylephrine, but to be honest, there isn't high-quality evidence for any pressor management. Next, I'm going to talk a bit about dopamine, specifically about its use in cardiogenic shock and the relevant trial called SOAP-2, which stands for Sepsis Occurrence in Acutely Ill Patients. This was a multi-center RCT with 1,700 patients presenting with shock of any cause. They are randomized to dopamine versus norepinephrine. There were virtually no exclusion criteria. As long as a patient was a non-brain-dead adult who was not having active life-threatening arrhythmias, they were recruited. The primary outcome was all-cause mortality at 28 days. On the surface, the trial seems really robust, relatively large, randomized, blinded, few exclusion criteria, and a hard, clinically relevant endpoint. So what did they find? The survival curves between norepi and dopamine were statistically identical, though notice that half of the study participants died within a month. These were very sick people. But that was not what was controversial. This was. It's the hazard ratios for death broken down by shock subtype, and the cardiogenic shock group seems to have done better on norepi, despite the fact that this was counter to common practice, counter to expert opinion, and counter to basic principles of physiology. Norepi is more vasoconstricting than dopamine, which, if you remember, is supposed to be a bad idea in cardiogenic shock, right? Well, the authors speculated that the difference is because dopamine causes more fatal arrhythmias than norepi. Essentially, it has too much beta-1 agonism. People got all excited in response to the trial's results. Guidelines and clinical practice changed, at least among critical care docs. Most heart failure experts, however, were unconvinced, and they pointed to several critical problems with the trial. First, shock was defined as the combination of a MAP less than 70 and evidence of tissue hypoperfusion. Unfortunately, this is not an appropriate definition of cardiogenic shock in patients with chronic end-stage heart failure, as they frequently have baseline blood pressures that low, and in fact, their cardiologists may be intentionally keeping their blood pressure that low with afterload reducing agents to maintain adequate cardiac output. Second, although this data was hidden away in a little seen appendix, in the dopamine arm, the mean dose of dopamine provided was 12 to 16 micrograms per kilogram per minute. This is much higher than typically used for heart failure. Remember that receptor selectivity of dopamine is dose dependent. At doses above 10, there is greater alpha-1 agonism, leading to vasoconstriction. In addition, more patients in the norepi arm ended up receiving open-label dobutamine, which was available as per the trial protocol. As dobutamine is actually considered by cardiologists to be the true first-line agent for cardiogenic shock, it's not a surprise then that the norepi patients did better. So the bottom line is that the SOAP2 results should not be applied to patients with cardiogenic shock, despite the fact that critical care docs throughout the world now do. I'm going to end here with a quote from a Cochrane review on vasopressors for hypotensive shock. I think this sums up the state of knowledge on pressor management pretty well. Quote, "The quality of evidence differs greatly between several comparisons, but in summary, evidence is insufficient to prove that any of the vasopressors at assessed doses are superior over others in terms of mortality. The choice of specific vasopressor may therefore be individualized and left to the discretion of the treating physician. Factors such as experience, physiological effects, drug interactions with other therapeutics, availability, and cost should be considered." So in other words, we just don't know. That concludes this video on pressors. If you enjoyed it, please consider liking and sharing it. And of course, thanks for watching.